Hello, ladies and gentlemen. The topic of our presentation is street medicine and its potential as a model for addressing the healthcare needs of homeless individuals. This is a collaborative project from the Keck School of Medicine at USC under the guidance of Dr. Julia Borove. The authors, Sarah Edemad, Leah Jacobson, Sarah Ramirez, and Cheyenne Sontag, are candidates for the Master of Science in Global Medicine. Homelessness is a global occurrence that transcends cultural and geographic boundaries, affecting heterogeneous populations in urban and rural settings. In the United States, homelessness is defined by the federal government under the McKinney-Vento Homeless Assistance Act as a person who lacks a fixed, regular, and adequate nighttime residence, which includes shelters or private or public places not designed for or ordinarily used as a regular sleeping accommodation for human beings. In 2007, using service provider data, it was estimated that approximately 1% of the U.S. population, or 3.5 million persons, experience homelessness each year. This figure may be an underestimate as it does not account for homeless individuals resistant to healthcare services. The challenge to producing more accurate data on the scope of homelessness results from difficulty in collecting information from a population whose condition can vary daily. Homeless individuals face adversity in many aspects of life, including challenges related to an increased burden of disease and barriers to obtaining medical care. Four prominent barriers to care are patient fear of stigmatization, lack of insurance or ability to pay, unreliable transportation, and survival concerns. Homeless individuals are at a high risk of a wide range of health problems and premature death. The street medicine outreach model offers medical services from vehicles or on-foot teams at sites most convenient for homeless persons. This model of service employs regularized routes and stops on streets, in camps, and at shelters for both scheduled and impromptu appointments. A literature review was performed to select medical outreach focusing on physician-led models. The results were evaluated on their ability to address the four selected barriers to obtaining medical care. Sociologist Irving Goffman defines stigma as a discrediting individual attribute or a spoiled identity. Many, but not all, homeless individuals have significant comorbidities, including substance abuse and mental illness. As a result of the mechanism of stigma, these stereotypes are inextricably linked to the identity of homelessness, which leads individuals to become isolated and disaffiliated from the community. The fear of being stereotyped and rejected by healthcare professionals is a significant barrier to care for homeless persons. Society places healthcare providers in a position of power, which can exacerbate the negative relationship between provider and the stigmatized individual. A survey of students in an institution in England found that attitudes towards the homeless become more negative after medical school. Because training of medical students involves an apprentice style of learning in which attending physicians serve as role models, some students suggested that the negative perceptions of the homeless may have been transmitted through disparaging remarks made by senior physicians and through observations of mistreatment of patients. The erosion of individuality that stems from being stereotyped can cause homeless persons to have a deep mistrust of the traditional healthcare system. This discrimination is compounded for persons engaging in illegal activities, such as substance abuse, for which they may fear arrest. The stress endemic to stigmatized groups can lead to depression and to a worsened clinical course. In order to provide effective care, a period of courting to establish trust with the homeless patient is essential to treatment. This courting involves understanding the patient's competing survival needs and offering them resources such as food, water, shelter, and connections to organizations and government assistance. In the context of individuals vulnerable to stigma, trust must first be earned before clinical examinations or treatment plans are implemented. The UCLA Mobile Clinic Project recognizes that exposing medical students to homeless patients during their training might prevent them from stigmatizing these individuals once they are practicing physicians. Ensuring consistency with the clinical team members visiting a particular patient is also critical to establishing trust. A mental health street practice in Seattle focuses on developing trusting, long-term relationships with their patients and recognizes that it requires a gradual and continuous effort. Lack of insurance and the inability to cover medical costs out of pocket is a significant barrier to homeless persons seeking ambulatory care. In the U.S., more than half of the homeless population lacks medical coverage. Many homeless persons cannot access primary care because they are ineligible for coverage under Medicaid as a result of not falling under one of the 6 eligibility groups. In addition, others do not qualify as a result of substance abuse and can become confused by the application and periodic reapplication process. Some homeless individuals, including veterans, may be eligible for coverage but are unaware of their benefits or encounter difficulties enrolling in the appropriate programs. Furthermore, enrollment in medical and social service programs often requires proof of identification or citizenship, which can be challenging for homeless individuals to obtain and retain. Many homeless individuals in the U.S. are unwilling to seek care until their health concerns become an emergency, at which point they can be treated under the Federal Emergency Medical Treatment and Labor Act, regardless of the ability to pay. As a result, homeless individuals utilize emergency departments with great frequency. Street medicine addresses the barrier posed by lack of insurance and money to pay for services by providing services free of charge to all persons. Programs like Operation Safety Net include social workers to assist homeless persons in obtaining documentation and medical insurance coverage, creating a bridge between homeless persons and community resources as well as ongoing primary care. Patients who received intensive case management were more likely to procure and maintain Medicaid and food stamps and have fewer hospital emergency room visits. Multiple studies based on interviews of homeless individuals cite one of the primary reasons for not utilizing ambulatory care as difficulty obtaining transportation. Many studies primarily focus on urban homeless individuals, but it is not difficult to extrapolate these findings to rural locales where public sources of transportation are more limited and the geographical distance between clinical sites is greater. When personal and public access to transportation are unavailable, patients are left to rely on the charity of friends or strangers with vehicles for a ride, or are forced to travel by foot to medical centers. Street medicine overcomes the transportation barrier and reverses the doctor-patient hierarchy by seeking out patients in convenient and comfortable locations, including shelters, parks, camps, and on the streets. The comprehensive care goal behind the street medicine model is to individualize treatment to the patient's lifestyle. In the absence of tailored outreach care, marginalized homeless individuals would be unlikely to access health services. For many homeless individuals, securing basic survival needs often takes precedence over seeking medical care. Daily survival priorities include food, water, shelter, safety, and hygiene facilities. The everyday struggle to procure survival priorities perpetuates a cycle of ill health. For example, inadequate and unbalanced diets can lead to malnutrition, while difficulty obtaining fresh drinking water can result in dehydration. Securing food and shelter on a daily basis requires substantial time dedicated to finding money, seeking a safe place to sleep, or standing in lines for food programs and shelters. Time spent on medical appointments may thus jeopardize a meal or lodging. Shelter or street residents may also be hesitant to leave their belongings for fear that they will be stolen during a medical visit. Additionally, when medical appointments and prescriptions require co-payments, homeless persons must often make financial decisions between spending money on food, laundry and hygiene, or treatment and medication. Competing needs can make adherence to treatment plans difficult and negligence of health commonplace. By targeting homeless individuals on the street and in shelters instead of in clinical or emergency room settings, street medicine programs have the opportunity to address health needs and survival priorities of the homeless. Several street medicine organizations have accomplished this through collaborative partnerships with other homeless services. For example, Operation Safety Net employs social workers to assist homeless patients in securing permanent housing. Multidisciplinary street medicine outreach teams have also addressed survival priorities by delivering medical care along with personal hygiene kits, emergency food pantry bags, clothing, and showers. Street medicine is a global field that aims to overcome obstacles to care for the unique and heterogeneous homeless population. It provides health care to those discriminated against by the traditional system as a result of poverty and lack of medical insurance. Outreach programs providing on-site health care for homeless in places where these individuals gather has the potential to successfully expand access to ambulatory care and reduce the burden on hospital emergency departments. The collaboration between physician and patient breaks the vicious cycle of helplessness and places autonomy back into the hands of the dispossessed population. Research on homeless outreach programs in general, especially on physician-led mobile clinic and street medicine operations, is scarce. Due to the selection criteria and a lack of formal publications, all forms of street medicine models could not be covered in this paper. Additionally, it should be noted that this paper does not cover all barriers to homeless medical care. We would like to acknowledge Marianne Romeo, Dr. Mimi Duhan, and the Santa Barbara Street Medicine Doctors Without Walls organization for helping to supply photography for this presentation.